Thank you very much for the invitation. And I have to tackle this problem to the treatment, the management of recurrent HCC following liver transplantation. I want just to stress some points as an introduction. First, when we are talking about HCC recurrence after liver transplantation, it means by definition that there was an infraclinic residual tumor or disease at the time of liver transplantation, and we should maybe talk more about a persistent and probably systemic disease rather than a recurrence, even when it is localized macroscopically. Second, the prevention was already discussed by my colleague, but I will say a few words of incidence, the pattern and the natural history of this recurrence, and how we manage this recurrence. Mainly, you know it, by opposing the local recurrence, localized recurrence versus multiple recurrence. So first of all, the incidence. The incidence has been drastically decreased by the implementation of the Mazzaferro, the Milan criteria, but it's still between 10 to 20% of cases. And second, it is usually within 1 year to 18 months after liver transplantation that we see these cases of recurrence. Often it is a multiple recurrence. It is more often extrahepatic than intrahepatic. And when it is extrahepatic, it is often the lungs, the bones, and the peritoneum. And the bone is a very important factor. I will come back on this point. The second point is the natural history. The natural history is very sad. You have here the survival after recurrence in 94 cases out of almost 500 cases transplanted in France for HCC. So the incidence of recurrence was 20%. And as you can see on the curve, I don't know if there is a mouse here. Yes. The median survival is very short, less than 1 year, and there is no long-term survival. So clearly, this recurrence has no individual benefit for the patient. And second, it reduced the utility for the community of the graft. And this problem is worsening because if you look at the proportion of patients transplanted for HCC, which is increasing everywhere, it is now in France a little bit more than 30% of indication of liver transplantation. Of course, due to this increasing proportion of liver transplantation for HCC, the burden of recurrence-induced graft losses rises in parallel. Now, the third point is the prognostic factor when there is a recurrence. This paper, published in 2004, is a very important paper because finally it gives all these prognostic factors. 3 factors are very important: the presence of bone metastasis, the time to recurrence, the shorter it is, the worse is the prognosis, and the possibility of a surgical treatment is a positive factor. And you have here on this slide 2 survival curves opposing recurrence after 1 year without bone metastasis and radically treated metastasis, which is significantly better compared to patients who have a recurrence within 1 year with bone metastasis and non-surgical recurrence. Now the management of this recurrence, I already quoted this paper, but I will go a little bit more in detail. We oppose usually the recurrence of a single site versus multiple sites. You have here this series of 132 patients transplanted for HCC. Recurrence rate was 16%. And you see here the resectable recurrence achieved survival at 4 years of almost 60% compared to 15% for unresectable recurrences. And this was clearly significant. So this is the second series. Coming back to the series of Royer, again, surgical treatment of recurrence versus no surgical treatment, there is a significant difference in terms of survival. This is opposing with or without bone metastasis. Another very optimistic paper published by Taketomi. You see here 101 living-related liver transplantation, 17% of recurrence after liver transplantation, and again, the surgical group of recurrence has a significantly better survival compared to non-operated patients, non-operable patients. But in addition, these patients with operable recurrence had a comparable survival compared to patients without recurrence. It's very optimistic, but I think it's the way to follow. This is our experience at Henri Mondor Hospital from 1990 to 2014. The recurrence rate was less than 10% because the criteria for liver transplantation for HCC were very stringent. And you see the first recurrence in the liver, 30% versus extrahepatic, 75%. Second, when we subdivide this small population into best supportive care, sorafenib plus resection, and resection, you see clearly when there is resection, there is an improved survival following this recurrence of HCC. One note of caution, when we have to resect part of the liver in a transplanted patient, you have here a series published by Daniele Somacal lately. He reviewed the world literature of resection on transplanted patients, and you can see that there are often recurrence of HCC in this series, and the morbidity rate was 62%, which is much higher compared to resection on a non-transplanted liver. So to say recurrence in the liver, resectable recurrence, we have to be cautious also when we decide to do a resection. So we have seen this localized recurrence, but the problem is when it is multi-site or unresectable recurrence. We have seen that the supportive care, there is no long-term survival, no mid-term survival, in fact, and we are now, I will try to tackle the systemic chemotherapy, the place in the changes in immunosuppression, and the place of sorafenib. These four randomized studies were performed as adjuvant treatment after liver transplantation for HCC, not for recurrence. But they showed these four studies. First, that the regimen doxorubicin-based don't work. One was stopped, and one had no impact on survival. So probably when the patient recurs, this type of regimen will not be efficient. It has not been yet published, but probably it will not be efficient. And there was one study that was interesting as an adjuvant treatment again, following liver transplantation for HCC with licartine, and showed that there was an improved overall survival and improved disease-free survival. So maybe this molecule, it's a monoclonal antibody, could be used in a transplanted patient with a recurrent HCC, but this remains to be done. What is the place of sorafenib? Of course, you will see in the literature papers showing the disappearance of some recurrences under sorafenib, and other series showing that the median survival can be interesting. The problem is the side effects. As you can see in this series, 60% of hand, foot, skin reaction, including grade 3 cases, neutropenia in 40% of cases, diarrhea is a big problem with this treatment, and clearly there is a place for sorafenib, but the side effects are very important. Another more optimistic series by Esposito and the collaborator from the Mazzaferro group, they compared 15 cases under sorafenib versus 24 historical cases with best supportive care for HCC recurrence following liver transplantation. There was clearly a gain in terms of survival for the sorafenib group, and in addition, in the multivariate analysis, the treatment with sorafenib was the only factor associated with the survival after HCC recurrence. So it's interesting, and in addition, in this series, the side effects were not so important with the sorafenib. Now, what should we do with the immunosuppression? Jan Lerud showed this slide showing from the Vivarelli study that the level of cyclosporine after liver transplantation is correlated with the risk of recurrence. And in multivariate analysis, the CSA, the cyclosporine exposure, the CNA inhibitor, was the only independent prognostic determinant at multivariate analysis. So we have to do something with this immunosuppression, and we are now moving to inhibitor, the mTOR inhibitor. And this series, only 7 cases, but it's interesting. Combining everolimus and sorafenib for recurrent HCC following liver transplantation, this study was done to check the efficiency and the toxicity, and clearly, you see here when we combine the two drugs, 70% had hand-foot syndrome, 30% had the diarrhea, 40%, a little bit more than 40% had asthenia or anorexia, and this leads in 30% of patients to stop the sorafenib, and in 40% of patients to decrease the doses. So we have a problem with this combination, which is interesting, but there are lots of side effects. So now We have this type of algorithm that is proposed how to manage the recurrence of HCC following liver transplantation. This was proposed by the Geneva group by Christian Tozo as an editorial following the paper by Esposito. And they proposed for this type of recurrence of HCC following liver transplantation, first of all, for all the patients, and this is logical, to consider the mTOR inhibitor, to decrease the calcineurin inhibitor, and probably to decrease the immunosuppression. We should add probably what Jan Lerud told us just before, probably to stop the steroids earlier in this population, even as a prophylactic measure. Then, when there is a recurrence, when it is strictly hepatic and resectable, or extrahepatic and resectable, we should go to resection. I think this is the way to go. When it is not resectable, we have the choice between different treatments, including the sorafenib. So my conclusion, finally, is that we are still 4 years after this consensus meeting about transplant for HCC. We are still stuck with some of the recommendations that we already had 4 years ago. First, there is no evidence to give adjuvant chemotherapy after liver transplantation today, except in a randomized study. Second, when there is a recurrence, if it is resectable, we should go to resection, adapt the immunosuppression, and probably move to inhibitor or mTOR. And of course, liver retransplantation is not indicated for recurrent HCC. Thank you very much.